Welcome everybody, and thank you for taking your time out to join us this morning for our COVID update. We're expecting quite a small group today, but that's okay. We hope to make this as interactive as possible. So before we begin this morning, I firstly would like to acknowledge the traditional custodians of the land on which we're meeting today, the Ngunnawal people, and I wish to acknowledge and respect their continuing culture and contribution they make to the life of this city and this region. And I would like to acknowledge and welcome any Aboriginal and Torres Strait Islander people who are attending today's meeting. So my name's Anne-Marie Svoboda. I'm a GP and I'm the Medical Director of the GP Liaison Unit at Canberra Health Services. And I have with me Dr. Adnan. Adnan is a GP and he is working for the COVID Care at Home team at Canberra Health Services. So we're going to have a presentation by Adnan and a couple of cases as well to help us with our discussions. We invite you to give us your questions, and we look forward to answering as many questions as we possibly can. The whole point of this is to be able to support GPs and care providers out in the community. So when time comes, if you want to, you can pop up your hand and we'll let you ask your own question, or if you prefer, you can just pop it in the chat box and I'll ask the question on your behalf. So Adnan, would you like, and at other times, if you could please leave yourself on mute, so that we don't get any feedback or interruptions to the presentation. Adnan, if you're happy to go ahead, do you want to start sharing your screen?
Yeah, thanks, Anne-Marie. Thanks for the introduction. I'll get going with the presentation. All right. So yeah, once again, everyone, thanks for showing up. So I just wanted to acknowledge and thank Ian and Anita, because a lot of the slides that have come from this presentation have come from their previous presentations that they've done. And if any of you had attended their sessions recently, some of these might be familiar to you. But I'll just sort of go ahead and get started. So the main things that I wanted to talk about today is the sort of key concepts and natural history of the COVID virus, which by now a lot of people are pretty well aware of. Some data from the Canberra Hospital, a bit about treatment pre-assessment, and this is, I guess, more to, think about the fact that COVID's here to stay, and it's about building in the sort of thinking about patients who are going to be eligible for antivirals and other outpatient treatments during a part of our sort of routine care. And then we're going to talk about the sort of main three treatments that we're using, the oral antivirals, Paxlovid and Lagevrio, and the situations in which, at least in ACT Health, we're using IV remdesivir early as an outpatient treatment. And lastly, I'm going to talk about access to Evusheld. This is probably the thing that's changed most in the last sort of couple of weeks, and we now have a bit more of a streamlined process for getting it out and getting it to patients. And then we'll obviously have time for Q&A throughout and at the end if needed. So I guess thinking about the key concepts, time really matters. There's a window of 5 days for getting these antiviral medications started from the time of symptom onset. And really the reason behind that is because they're all designed to sort of inhibit viral replication in that early phase before people actually end up getting sick. Vaccination is also very important. We often don't ask about this, but it is relevant in terms of antiviral access, because some people may be young and unvaccinated, but they still be at quite high risk. And in those situations, giving us a call at the COVID Care at Home team would be quite helpful, because we have access to medication from the National Medicine Stockpile that we can supply. The other important thing to know about vaccination is we're still not doing fantastic with our booster rates, and that's it's going to be an ongoing, I guess, work in progress. But I guess similarly, if you're coming across patients that you think are high risk and would be eligible, just giving them a quick nudge or a reminder, like we do for all of our other sort of preventive care items. And then, the risk for deterioration is cumulative. At which age being probably one of the big risk factors. But the more risk factors you have, the more at risk you are for progressing to sort of severe disease. And as I mentioned, thinking about early antiviral before a person gets COVID is going to be a way moving forward. Lastly, I want to mention about steroids, because there has been some cases of people using steroids still in that early phase. There is a role for steroids, but it's more after that sort of first week when people are actually in hospital. And if you use steroids too early in the sort of treatment course or in the course of people getting the virus, is actually worse outcomes. So really important that we don't do harm by sort of starting people on steroids early on. Now, they can be a bit tricky when people that have really severe asthma that might need steroids for managing their asthma when that flares up with COVID. But, you know, I guess it's a discussion to have with patient, and we do need to sort of have that balance about trying to inhibit the response they're getting from the asthma versus inhibiting the immune system too much and not being able to fight off the virus. So, you know, I guess this is really just to hammer down the fact that, you know, people that end up in hospital are often in the sort of second, often after sort of 5 to 7 day time period, whereas the window for the antivirals is really early on in that sort of viral replication phase. Once you get into that sort of second inflammatory phase, that's when we end up using steroids and other treatments within hospital. They may need oxygen support and you know, really severely progressing into sort of ICU for other respiratory support as well. Yeah, so I guess thinking about the symptoms that they are getting, and then you know what are the risk factors. Oftentimes, yeah, older age, and then the cumulative risk factors like obesity, chronic heart disease, COPD, all of these, and I guess immune suppression is the other big one to be thinking about. This is just another slide, once again going over the point that as you get older, risk increases, and as your risk factors increase, your risk for disease progression increases. So I won't spend too much time on these because they all sort of go through the same point really. This is the cases from the hospital, and you can see obviously there have been sort of peaks and troughs, and now we're sort of on the downtrend again. We really have seen a massive decline in sort of COVID case numbers over the last sort of few weeks, and that's reflected in the hospital admissions now as well. People who are admitted with COVID pneumonitis. It is interesting though, contrasting the people that have come through our program at COVID Care Room that we're aware of, and you can see that there's definitely a skew towards a sort of younger age range of people that are coming through the program. But when you look at the data of people that are actually being admitted, there are still, it's definitely much more heavily skewed towards the older age group. So part of the issue is we're still missing getting treatment early and getting in early to treat some of those sort of older patients. And part of that could be because of the way the COVID Care Home program is set up and the public health notification set up. People are not registering the RAS, people are maybe not getting tested, and people are maybe having difficulty with the IT questionnaire, which is what we use to sort of reach out to people who are at higher risk. So the focus of this talk is going to be on that early antiviral phase and what the treatment options that we really have in that time frame. So the main options really are Paxlovid and molnupiravir. These are the two options that most people will be using in general practice. And then a small subset of people could also be referred for IV remdesivir within the sort of first 5 days. Paxlovid is definitely the first line option. It has the highest efficacy and followed by remdesivir, but because of the issues of remdesivir needing to be given IV over 3 days, we moved down to sort of molnupiravir, aside from certain very, very high risk people if they can't have Paxlovid. So once again, going over the sort of data in the trials, so sotrovimab we're really not using anymore, essentially because it doesn't have any efficacy against the BA2. There is bebtelovimab that's available in the US. Whether or not it's going to end up coming to Australia, it's still a question mark, because I think we found a bit of we're finding more and more with the new strains, some of these expensive monoclonals become irrelevant pretty quickly. And then lastly, Evusheld, which once again did have quite a strong role early on, but the data behind its efficacy now is actually reducing already, unfortunately. So becoming, and I'll have a bit of information about that later on. And then the treatments that we don't want to be doing, which might be causing harm: ivermectin, hydroxychloroquine, steroids, antibiotics, azithromycin, no real evidence. And there's been now plenty of studies to show that there's no real evidence for any of these treatments. So just a brief plug about the ACT Health. They've created a pro forma for antiviral pre-assessment. Now, really you don't actually have to use this within your clinical practice, but it's a helpful guide, and it's something, if you do want to fill it out and give it to patients, something that patients can have on hand. But really the main important thing is having those conversations with patients early on ideally before they get COVID, giving them the instruction that, if you do get COVID, there's a window period. If you have negative RATs, maybe go get a PCR if you're high risk. And then as soon as you have a positive result, get in touch either with your GP or with your specialist to let them know. And we've got those telehealth item numbers as well for the COVID antiviral pre-assessment, 93717 and 93716, which have actually been extended for a bit longer for ongoing use by GPs and specialists. So in terms of the considerations for oral antivirals, so obviously symptom onset is very important, because we need, from 5 days within the symptom starting. Diagnosis either by RAT or PCR, and the RAT does not need to be visually verified. You can just confirm based on the patient giving you the information of when they did the RAT, and just document that in their notes, and ask them if they've registered it with ACT Health. All the oral antivirals are approved only for adults, so we're not using it in pediatric population. We don't have much data on using it in pregnancy and breastfeeding, and it's not approved for that indication within Australia. Although in the US there is some move now towards using Paxlovid in pregnancy, but I guess it's a bit of a watch this space whether it becomes approved in Australia for that function, for that purpose, that population. And lastly, when we're thinking about Paxlovid, the renal function, hepatic function, and drug interactions is also quite important. But wherever possible, Paxlovid should be the first line option. So a few instances, and really the reason I'm focusing on these particular medications is because there have been some admissions in hospital from people that have been given Paxlovid that were on tacrolimus or colchicine. So they've actually ended up having quite an adverse reaction to Paxlovid and ended up in hospital because of the side effect of the drug, as opposed to because of COVID. So something we want to sort of keep in mind. And I guess give us a call if you have any confusions about drug interactions and how to sort of work around it. And then there's always, and check everything on the Liverpool interaction checker, which we'll sort of go through a bit. So the PBS authority codes keep changing. They've changed again quite recently, and I'm not quite sure why, but currently these are the sort of main indications. So if you're above the age of 70, you don't need any of the risk factors, you get it. If you're immunosuppressed, above the age of 18, you can have the antivirals. If you're above the age of 50 with 2 or more risk factors, or if you're Aboriginal and Torres Strait Islander above the age of 30 with 2 or more risk factors. I think if you're using a practice software like Best Practice, it'll be updated. I haven't had any knockback, even though I think there have been a few that I've prescribed that have been an incorrect item number, but the pharmacist should usually call them back. And I think the pharmacists are quite cued onto this, and because they're the ones that sort of need to use the appropriate codes for getting the reimbursements. But I haven't had any calls back, and hopefully it shouldn't be too much of an issue if you've got a practice software that will update automatically. Now, a couple of other points with Paxlovid. There's 2 different dosing regimens. So if your eGFR is greater than 60, then you have the full dose, which is 300 milligrams of nirmatrelvir with 100 milligrams of ritonavir taken together twice daily for 5 days. So that's going to be 2 tablets of nirmatrelvir, each 150. If the eGFR is between 30 and 60, then it's going to be 150. So 1 tablet of nirmatrelvir with the full dose of the ritonavir, twice a day for 5 days. Less than 30, once again, not approved for use in Australia, but this is being used. There are renal dosing regimens that are coming up overseas in the US and Canada. So it might be something that we maybe move into the future, but not yet, has not yet been approved by our sort of TGA. So if you do have a patient that does have severe renal impairment, less than eGFR of 30, and you are wondering whether Paxlovid would be an option, once again, give us a call. We'll probably liaise with the renal physician and look at the data and see if they're okay to, we want to sort of do that modified dosing, which is being used overseas. So the Liverpool interaction checker, I think it's fantastic, available online or on an app, and it gives you, you can type in whichever medication you have to. Really just need to do it for Paxlovid, no need to do it for remdesivir or molnupiravir because there aren't any interactions. But really for Paxlovid, you can type it in and it sort of goes through the different interactions that come up. And I will run through a few cases just to sort of highlight that a bit better. So the first case is about a woman with immunosuppression, who's sort of day 4 of her illness, has been vaccinated ×4, and is on ocrelizumab for her MS. So ocrelizumab, rituximab, these are some of the medications that have one of the worst outcomes for people with COVID. Don't fully understand the mechanisms, but they're definitely one of the highest risk groups. Anybody who's on this medication. She also had a couple of other risk factors. She's got asthma, got slightly elevated BMI as well. And she's got a few medications that are on her file other than the ocrelizumab. So when you punch that through the drug interaction checker, you get that there's a minor interaction with amitriptyline, but she's on a very, very low dose of the amitriptyline. So you can either keep the dose as it is, or you could halve it, would be the other option. But because she's on a very low dose, I think in this case we had ended on carrying on with it. And obviously for a woman of childbearing potential or age range, you do need to sort of discuss the implications for pregnancy, which if you're using molnupiravir, we advise not to get pregnant within 1 month of use if you're female, 3 months if you're male, and for Paxlovid, making sure that you use sort of contraception while you're on the medication and avoid getting pregnant while you're on the medication. So the second case is a 32-year-old male who's in second day of illness, vaccinated 3 times, identifies as Aboriginal, and he's got a few risk factors. 3 risk factors really is his diabetic, his BMI is elevated, and he's got cardiovascular disease. So this one has changed recently. Previously, it used to be only somebody who has a congestive heart failure, but now they've expanded the criteria a bit to include people who have coronary artery disease. So he'll have 3 risk factors, and he meets the criteria, and that's his list of medications there. So once again, plugging that into the Liverpool drug interaction checker, his statin is the one that's the problem. But in cases of statin, you can just sort of stop the medication. Usually we do it for 8 days. You could substitute pravastatin or other statins. I honestly don't sort of worry about that too much. If they're on a statin, stopping it for a few days is not going to have a massive impact on their overall risk moving forward. And it's just more of a hassle to try and organize a whole bunch of other medications. But if a patient does want to and they're really keen on that, that would be the other option to sort of go with. But I find most people just want to keep it simple. They just stop the medication and withhold it for a few days. And his EGFR is normal as well. So the next one is a 71-year-old who's day 4, vaccinated ×4. He's also got a few risk factors, including lymphoma, previously and a recent PE, which we'll sort of cover in a second because that has implications. So as far as his medication list goes, he's on a few, but there are a couple here that would be contraindicated with Paxlovid, in particular the sort of rivaroxaban and the Tarjan. Now, given his sort of recent PE, it'd be I would feel quite uncomfortable trying to sort of stop his anticoagulation. So in the Tarjan or other sort of opiates, a lot of people do take them PRN, so sometimes you can sort of stop that or reduce the dose, but the anticoagulation does pose a bit of an issue. So you could start them on Clexane, but then you have to delay the starting of Paxlovid by 24 hours, and he's already at day 4. And I guess with all of these medications, the sooner you do take them, the more effective they are. So in this case, we ended up going with molnupiravir for this gentleman, and it's 4 tablets twice a day for 5 days. So now we've got a 50-year-old gentleman with 2 risk factors, and he's vaccinated ×4. So he's got rheumatoid arthritis, depression, asthma, and renal impairment. So that's his list of medications there. And interaction-wise, it's really just the Plaquenil has a very mild interaction. So you could either stop it or reduce the dose once again, and those are that would be if you wanted to sort of go with Paxlovid, and then Yeah, so side effects that we want to discuss, metallic taste, nausea, loose stool. I should have probably mentioned that earlier, but that goes with all of the antivirals. And ended up going for a reduced dose of the Paxlovid for him, and carried on with that. Without, I think we didn't do any changes to his dosage of Plaquenil. So a couple of special cases, and probably the big one here is if you're unvaccinated with several risk factors and under the age of 50, then you don't quite meet the sort of criteria for PBS unless you're immunosuppressed. And in this situation, you could give us a call and we can organize it because we can dispense the medications from the national stockpile. So we had an unvaccinated gentleman who was 45-year-old with a range of risk factors, and EGFR sort of just in the sort of normal, in the range for the full dose of Paxlovid. And then he ended up getting the sort of Paxlovid from our stockpile. I guess with those with an EGFR and the borderline, sometimes you might feel a bit more comfortable getting an EGFR just to make sure that they're still within that sort of normal range. And for those, you can send them. It'd take a bit of calling around, but you could once again call us, and we could arrange them to have a blood drawn at the Garan walk-in clinic. But I'd probably be still starting them on the full dose of Paxlovid, and then you can make an adjustment to their dosing if their EGFR is lower. The other special case we wanted to briefly mention was an unvaccinated pregnant woman who was 16 weeks pregnant with multiple risk factors. So she's got type 1 diabetic, severe asthmatic, and elevated BMI. She can't have any of the orals because of it's not being indicated in that population. But remdesivir would potentially be an option. That being said, the evidence for use of remdesivir preemptively in pregnant women is pretty sparse. There's, we use it a lot for treatment down the track if they end up in the sort of inflammatory phase. So you do need to, I guess, have that discussion with the patient to see if they would want to sort of proceed with it, or if they'd want to if they're fully vaccinated, or they just want to hold off. But I guess it's a discussion to have with the patient. In this case, the patient did end up choosing to go with remdesivir, and that's something we organized through the Garan walk-in clinic, where they come in day one, have a dose and get a cannula put in. They leave with the cannula inside you, and then come back on 2 subsequent days for the remdesivir infusion. The other sort of special case is organ transplant, and a lot of these people will not be able to have Paxlovid because they'll almost inevitably be on tacrolimus or sirolimus or cyclosporin. So in these situations, we can do the remdesivir as well. So if you just call the COVID care home team, if they're within that sort of first 5 to 7 day window, we can arrange this. So with remdesivir, there is a slightly longer window for IV for treatment, and we push it out to sort of 7 days for the preemptive treatment. So so essentially this is just going once again through his list of medications and his risk factors, and he does have a few other things going on as well. And he did end up coming in for those 3 doses. So the first dose is 200 milligrams, and then 2 subsequent doses of 100 milligrams each. If they have poor renal function, we can still sort of give it to them if their EGFR is under 30. But we would have a modified dosing for that, and probably just be a 2-day course instead of a 3-day course. And it would be something we discussed with their renal physician before we went ahead. If they haven't had a renal function or liver function in quite a while, then we might sort of do that preemptively as well, because remdesivir can sometimes cause some transaminitis. So it would be useful to get a baseline. That being said, the risk of transaminitis in those sort of first 3 days would be pretty low. It's usually people that are in hospital for a prolonged period of time and on remdesivir for a much longer duration that they end up with those side effects, with that complication. And usually it resolves once you stop the remdesivir. The liver function does usually settle back down. So the last thing I want to mention is Evusheld. So this is now available for access by GPs and specialists through the pharmacy at the Canberra Hospital, and there is a form that you can sort of fill out to sort of get access for this, and the form kind of goes to the people that would be eligible. So this is available. I think the best place to access it would be through Health Pathways, and they have the form available there. But it's essentially people that are on those sort of high risk B and T cell inhibitors like rituximab, ocrelizumab would be the highest risk category. People that are on BTK inhibitors or had a stem cell transplant. And then other, once again, lung transplant patients, people with severe uncontrolled HIV, and other sort of immune deficiencies. So not just standard risk people that would be necessarily getting the antivirals, people that are slightly higher risk. And essentially what this is meant to be, it's a combination medication which will hopefully, the theory is prevent the, neutralize the virus before it sort of gets into your body and causes havoc if you're unable to mount an immune response from the vaccine because you're on these immune suppressant or you don't have a well-functioning immune system. So generally, if you did want to access it, you just need to fill out the form, send it over to the COVID pharmacy along with a script. So that will be a handwritten script for Evusheld. And if you send that over to the pharmacy, they can then dispense it to the patient directly for administration, either back at the GP or with the specialist. Most of these so far have been organized by specialists within the hospital, but private specialists now can access it as well. And then they can get the patient to come in and the nurse can give the injection when they come in. Important to maintain cold chain for this. And in terms of the dosage, there's two components to it, the tixagevimab and silgagevimab, and it's 150 milligram each IM buttock injection on each side. And then as with most IM injections, you usually need to monitor them for about 15 minutes after the injection. In terms of the sort of risks associated with it, it is pretty safe and well tolerated, like a lot of the other monoclonals. If they're on blood thinners and stuff, they might have a bit more bruising because it's an IM injection, so same risk as any other IM injection. And there is, in the studies that they did initially, there is a slightly higher signal with clotting events, so cardiovascular events and PEs in the people that did receive the Evusheld. That being said, it wasn't clear whether or not that was related to the drug itself or whether that was a random chance. But that's something I guess you just need to discuss with patients and thinking about the sort of risk-benefit profile for getting this medication or getting this treatment. And I guess thinking a bit more about the risk-benefit profile, as I was mentioning right at the beginning, the evidence for its benefit is reducing, unfortunately. So there's a significantly reduced efficacy with the new strains using sort of Evusheld, which is over here. But then, with remdesivir, molnupiravir, and Paxlovid, you do still retain that efficacy. So still, even if they do receive Evusheld, they should still be getting remdesivir or molnupiravir or nirmatrelvir if they get infected. So Evusheld is just preemptive treatment for passive immunity, and usually lasts about 6 months once it's given. So that pretty much concludes the main topics that I wanted to sort of talk about. I know I ran through it rather quickly, but I think some of the people in the group have already been to the presentation, so I didn't want to sort of dwell too much and keep it going on for longer than necessary. But if anybody has any questions about any of these, please let me know or let us know, and we'll answer it right now.
Thanks so much, Adnan. Do you want to stop sharing your screen so that we can see just who's online?
Yeah.
So if anybody does have a question, please feel free to pop your hand up, and and you can unmute yourself and ask your question. Otherwise, if you want to pop your questions in the chat box, and I'll ask for you. I'm going to ask a really dumb question to start off. I feel really silly asking this, but what's the difference between pneumonitis and pneumonia? Why are we calling it pneumonitis rather than pneumonia, viral pneumonia?
This is a good question. I don't know. I don't think I would know from the top of my head. I'd probably have to ask Ian about that.
Ian, yeah. Sorry.
There might be something in the pathophysiology that distinguishes it. And it probably has something to do with the way in which the consolidation takes place and the way in which it's the consolidation organizes itself. Like if you go back to that image where you saw the where the X-ray image was up, I think with pneumonitis it's much more diffuse, whereas with pneumonia you have a specific area of consolidation, because the end process is that it leads to what looks to be ARDS. And they basically go into sort of a respiratory failure from that, and that's what ends up killing you, and that's what ends you in ICU and killing you. So it's a very diffuse lung inflammation, as opposed to a certain area of consolidation. I think that's why. But
it's reassuring to me you don't know fully, but I think that makes sense what you said. Yeah, I think it's like a inflammatory, I suppose, is when you were talking. It's the inflammatory.
It's an inflammatory.
Yeah. Okay, because of course people do still get pneumonia, so they still can get bacterial pneumonia and other sort of consolidation, which isn't necessarily pneumonitis. So I was interested in knowing how they're distinguishing it.
Yeah. I mean, I don't know in terms of treatment. Like, if they end up getting that unwell and end up in hospital, then realistically they'll probably end up getting both antibiotics and antivirals and steroids and all the whole shebang.
Yeah. Okay. And coming to steroids, in your presentation, you talked about early use of steroids and avoiding that early use of steroids. I presumed you were actually talking about the early use of oral steroids being contraindicated.
Yeah. Well, I mean,
as opposed to inhaled corticosteroids.
Yes. Sorry. Yeah. I didn't sort of clarify that. Yes, I meant oral. Yeah. Systemic steroids.
Yeah. And the budesonide is still recommended by the task force.
It is, yeah. Budesonide and ciclosinide as well are both still recommended. Yeah. Once again, I think so. The evidence for that is a bit questionable. Like, I think the Americans have dropped it from their recommendation because they don't think there's enough recommendation. I think it's the same with the Europeans. It's still on our task force guidelines. So I think it's reasonable to use, and it's not going to cause major harm if it's just locally delivered steroids.
Fantastic. Thanks, Adnan. Leanne, you had a question. You've got your hand up.
Yeah, it wasn't actually a question. I was just going to let you know, Adnan, that at the Garran Walk-in Centre, as of the 29th of this month, they will no longer be seeing COVID positive patients. They'll now be seen at the WIC in Western Creek. So just if people are wanting to check their EGFR, we'll have to send them. Yeah, that's all changing as of the end in about 2 weeks. Yeah.
Thanks for updating us on that. That's quite relevant.
Thanks, Leanne. We'll make sure that message goes out to GPs as well through the newsletter, through the GP Liaison newsletter.
Okay.
Okay. Any other questions from anybody out there? Or else I'll keep asking my questions I've thought up. Adnan, are there any other therapies coming down the pipeline in the future? Are we hearing anything about other oral antivirals or other therapies?
Not in the outpatient space. I think during his grand rounds, Ian talked about some other medications that might be relevant in the inpatient, like if they have progressive illness, but not so much as a early therapy. So as far as I'm aware, this is it. So we're in sort of steady state now with the treatment options as far as the outpatients go, and I suspect it's going to sort of taper off in the inpatient space as well, because who is declaring the end of the pandemic, and money's going to dry up, and pharmaceutical companies aren't going to want to invest in it anymore.
Yeah. And do we think that there'll still be a role, though, for the oral antivirals as we, continue to have COVID?
Yeah, look, I mean, I think vaccination really changed the landscape a fair bit, and all of the oral antivirals were initially marketed on people who are unvaccinated with risk factors. So the number needed to treat was a lot lower. There is still a role, and I think the role is probably more in terms of proper patient selection and giving it to those that are sort of at highest risk. But your number needed to treat will be a lot higher in a place like Canberra, where we have a very heavily vaccinated population. So I think it's going to be out there, but I don't know. I'm not quite sure exactly how much demand there's going to be moving forward.
Certainly, I mean, anecdotally, you know, all of my patients are doing incredibly well when they've had COVID. In nursing home patients, which is really interesting. And I'm sure you're right, the vaccination status of people is so important. Having said that, I think you were right. You pointed out, you know, that we do need to be vigilant about people and their boosters. I'm certainly coming across more and more people who I'm noticing are, you know, overdue. And have had some hesitancy around getting their vaccines updated.
And I guess now, the other thing is with the new Moderna strain coming out, this sort of that's another push or something to sort of mention to patients if they're feeling hesitant. And then thinking about Novavax as well. I think Novavax especially has had a much greater role in the US because they've had so many people who are unvaccinated that are waiting for a more traditional kind of vaccine. But there might be those people here in Canberra as well that you know had a lot of qualms about the new technology of mRNA vaccines or the clotting stuff with AstraZeneca. So for them, the Novavax would be a good option to think about.
Right. Still no questions from the audience. Goodness me. Louise, I'm going to have to pick on you soon to get you to ask a question. How recent should the renal function be, Adnan? I do notice, you know, many of my patients, you know, look, it's 12 months since they've had their last renal function. Is it still okay to use Paxlovid in those situations where they've got, you know, perfectly normal renal function, but it might be a little older than I would have liked?
I'm pretty comfortable using it. I think it kind of depends on what level of renal function you're comfortable accepting. If they're young, otherwise don't have a lot of risk factors, then I wouldn't be too worried about even if it's 12. I've even pushed it to more than 24 months personally. I think if they're old and doddery and they have a lot of risk factors, or the EGFR is a bit borderline, that would make me a bit more nervous, and I want something a little bit more recent, ideally in the last 6 months. But otherwise, if they're known to be stable and no renal issues in the last sort of few years, I think I'm pretty comfortable pushing it.
Okay.
And a lot of the young immunosuppressed people as well might often not have many bloods done or not have bloods in a while as well, and I'm often pretty comfortable with those population as well, as long as they've had one in the last sort of 2 to 3 years.
Yeah, and I'm the same. So long as they seem healthy and nothing has changed medically, I'm happy to accept a slightly longer range for the GFR. Oh, Louise, you've got your hand up. Please ask your question.
My question, well, it's not really a question. One thing from a health pathways perspective is that we really want to try and support people to choose Paxlovid because it is the better medicine, and I understand it takes longer to check the interactions. And how does anyone in the audience have any suggestions for how we can better support it? I mean, we clearly state that it's better. We link to the drug interaction checker. But any suggestions for how we can support Paxlovid use?
Adnan, do you have any suggestions for Louise?
No, I don't have any great. I think it's like a lot of other things in medicine. Just the more you do, the more comfortable you get. Like I think I nowadays I just look at the list and I know, but it's because I do it all the time.
Yeah, I'm the same. So the more you use it, the more comfortable you are. So I guess that's where, having these sorts of education events, encouraging people and speaking to your colleagues as well, to encourage them to use Paxlovid where it's possible.
But I think call us as well is the other thing. Just call the COVID care home. If you have any qualms or you have any questions at all, just give us a ring. We're around. Our workload has definitely plummeted, but so we have capacity to sort of chat through and do one-on-one teaching and education to help people get more comfortable.
Having said that, Adnan, I do, for many of my nursing home patients, I've used molnupiravir because they haven't got GFRs done for years, quite commonly, and often on multiple medications, and they have all done incredibly well. So I've had no deaths in any of my home patients. And I'm interested to know, do we have any data or information in regards to admission rates for people who've been started on antivirals and whether there's any breakdown?
We're trawling through that data at the moment. Within the hospital. We don't, so we don't, it's a work in progress, but we're trying to sort of analyze that and break that down.
Yeah, because that would be really interesting and help inform us about appropriate choices as well. And that's, you know, real life data from our population.
Yeah.
Adnan, do you have any advice for what to do around stopping immunosuppressants? So I'm thinking particularly for disease-modifying agents for people when they have COVID infection. So not necessarily related to the prescribing of Paxlovid, but to help their immune system combat their COVID infection.
Yeah, I mean, I often sort of refer this back to the specialists who's prescribed them their immune suppressing medications, because I find, and I often ask the patients, a lot of times they tend to have a plan, like from you know, if you get sick, stop your methotrexate or stop your other immune suppressant, or skip a dose for the next week and then carry back on. So I'll often just discuss that with them at that point in time, and potentially just have get them to sort of call the specialist, because I guess, and it kind of depends a bit as well on how well their disease is controlled. If the disease is quite well controlled, you can probably stop without it being a major issue. But I think if you know, you always have to weigh that up with the risk of things flaring up, and if they're difficult to control, they're on multiple immune suppressants, then it does become a bit trickier to sort of gauge. But I would probably be liaising with their specialist about that, unless I know their situation very well, and I'm comfortable saying, yep, I think you can hold off on it for a week, with, I guess, the caveat that, you know, if you find that things are flaring, maybe start back up on it, or
yeah, that's a good answer. All right, well, it's just coming on to 8:45. So these are just fairly short presentations. We like to keep it short and sharp so everybody can get back to work. Does anybody have any final question or comment before we sign off for the morning? I'm going to take silence as no, and I don't see any hands up. Well, thank you everybody for joining us. Once again, Adnan, it's been really helpful and fantastic to hear the presentations and the cases that you used really help to highlight the importance. We won't be having very many more of these type of COVID education sessions, but if you do feel you have any need for any questions, then please contact the COVID Care at Home team. We have 5 GPs who are there, or you can contact the GP Liaison Unit as well, and we can direct you to the appropriate person. So with that, I'll leave you to get back to your days. Goodbye, everybody. Have a great day.
See ya. Thank you.